So I think my presentation will be a clear description of it's a matter of perspective. I chose to adjust the question a little bit, and I added the word standard. And at this point, I would say that in the standard treatment, or does standard chemotherapy have a role in the treatment of metastatic melanoma? The answer is no. Key points: no chemotherapy at this point, excepting the German study that was just presented, has been compared to best supportive care. No chemotherapy has demonstrated an overall survival benefit to date in the treatment of metastatic melanoma. Chemo-resistance mechanisms are still under investigation and have yet to be overcome. Ipilimumab, vemurafenib, I'm going to take the liberty of adding in dabrafenib given the significant progression-free survival and immature overall survival data to date, and trametinib are the first agents to demonstrate a significant survival benefit in the treatment of metastatic melanoma. Ipilimumab and dabrafenib have surpassed the results of fotomustine and temozolomide in the treatment of brain metastases in melanoma. And at this point, I would argue that the role of chemotherapy in melanoma is only in the context of clinical trials in combination with novel immunotherapeutic and molecularly targeted agents, and then a small clinical exception of patients eligible for isolated limb infusion and isolated limb perfusion, where melphalan is the only established agent at this point. Dacarbazine we're all familiar with. A generous response rate was generated by this meta-analysis. Never been compared to best supportive care, and yet considered the gold standard for decades in the treatment of metastatic melanoma. Temozolomide, another alkylating agent, which adds methyl groups, as does dacarbazine, with the advantages of penetrating the blood-brain barrier and orally bioavailable. Initial showed impressive response rate at 21% and median overall survival at 5.5 months. In 2 randomized phase 3 studies, unfortunately did not show any significant difference in overall survival compared to single-agent dacarbazine. Nitrosourea is made up of carmustine, lomustine, and fotomustine. Again, the advantage of penetrating the blood-brain barrier, with overall response rates ranging from 10 to 20%. Fotomustine, not currently available in the United States, has demonstrated response rates again in the 12 to 47% range in phase 2 studies, but compared to single-agent dacarbazine, while the response rate was approximately double, there was no significant difference in overall survival. Platinums and taxanes have all been looked at, as well as vinca alkaloids, with general concepts of response rates roughly in the 10 to 20% range. Most recently, nab-paclitaxel has shown some promising activity, primarily in treatment-naive patients, where the response rate for treatment-naive patients in a phase 2 study was 21.6%, with an median overall survival of 9.6 months. The most recently presented data, I would argue, is a matter of perspective. Do you consider a progression-free survival improvement of 2.5 versus 4.8 months significant when overall survival and response rates are not considered significant in this study? So dacarbazine is not, or other single agents are not necessarily better than single agent dacarbazine, and single agent dacarbazine we have not proven is better than best supportive care, or multiple agents better than single agent chemotherapies. CVD versus DTIC failed to show a significant difference. The Dartmouth regimen in a larger phase 3 study, as well as a smaller randomized phase 2 study, failed to show a significant difference compared to single agent dacarbazine. And while carboplatin paclitaxel has not been directly compared to single-agent dacarbazine, I would say that there was, the response rates that you see there are fairly similar and in the range of what we see with other single-agent chemotherapies. In addition, comparing single-agent or multi-agent chemo versus biochemotherapy, again, promising response rates and activity in the phase 2 setting. That was not supported in further randomized phase 3 studies. Here, CVD versus biochemotherapy, both at a single institution as well as the Eastern Cooperative Oncology Group sponsored study. And multiple meta-analyses, this one from the Cochrane database comparing chemoimmunotherapy versus chemotherapy, a meta-analysis of DTIC versus multi-drug containing regimens from 20 different studies, as well as a systematic review of 41 randomized controlled studies comparing dacarbazine versus polychemotherapy, all demonstrated improved response rates, but no significant impact on overall survival. Ipilimumab has clearly shown an impact on overall survival, initially either with or without the addition of GP100 vaccine compared to GP100 vaccine alone, as well as in combination with dacarbazine versus dacarbazine alone. This was supported in an interesting systematic review that involved a network meta-analysis where Kaplan-Meier curves were digitalized and superimposed, and they came up with an expected overall survival for ipilimumab of 3 milligram per kilogram that was 18.8 months, compared to roughly 12 months for either single-agent chemotherapy combinations, or biochemotherapy. And I think we would agree that ipilimumab for the most part is well tolerated, side effects for the most part are typically manageable, and this is also an option for elderly patients. Ipilimumab has also shown activity in brain metastases. This is from a retrospective review of 12 patients that were included in a randomized phase 2 study of ipi with or without budesonide. And as you can see on the side, these 12 patients had the typical expected progressive disease, stable disease, and partial response. However, the overall survival for 3 of these patients was greater than 50 months. 1 of them was greater than 30, and that is obviously significant in the setting of brain metastases. Additionally, phase 2 study involving melanoma with brain metastases in 2 cohorts, group A without symptoms or steroid use, and in group B, symptoms and steroid use, show a significant intracranial response for cohort A of 16%. The overall global response rate is as expected roughly, and not surprisingly, cohort B that was symptomatic and on steroids did less well compared to those in group A. MAP kinase inhibitors, based on BRIM3, BREAK3, and METRIC, we clearly have agents that have activity in metastatic melanoma. BRIM3, I'm not going to go into gory detail as this has been presented on several occasions, but clearly showed an overall survival benefit compared to dacarbazine. And as you can see, the response rate for dacarbazine appears to decrease over time. Its response rate in this study is 5%. The update confirms similar findings of response rate, with a complete response, again, that's typically reported, and Dr. Kim alluded to, of 1 to 2% for dacarbazine alone. The overall survival benefit, median overall survival, is 9.7 versus 13.6 months. And while the hazard ratio did decrease to 0.7, that's in the setting of patients going on to receive further therapy, 44% in the DTIC arm. Additionally, there is some evidence that there is some activity of vemurafenib in the brain as well. The BREAK3 data, while this is a randomized study with PFS as the primary endpoint and immature, but overall survival hazard ratio of 0.61 was presented, and given the response, I think it is reasonable to expect that this likely will provide a true overall survival benefit. And response rates, again, are similar to what was seen for vemurafenib versus dacarbazine. Dabrafenib also has activity within the brain as well, which is significant for our patient population. Out of 10 patients that were treated in the phase 1 study of dabrafenib, 9 evidenced some element of response in the brain, and 4 achieved complete resolution. In the BREAK-MB study, which was a phase 2 of dabrafenib in patients with brain metastases, there were 2 cohorts of patients. Cohort A, as you see above, had no prior brain therapy, and cohort B had progression following prior brain treatment. Here I've focused just on the V600E BRAF mutants, but this included V600K mutants as well. And as you can see, the intracranial response rate for cohort A was, and cohort B ranged from 30 to 39%, which is certainly significant, and including stable disease within the brain that approached 90% in cohort B. The METRIC phase 3 study of trametinib versus dacarbazine or paclitaxel, as you're familiar with as well, showed an overall survival benefit, which again is significant given the crossover of 51 patients to trametinib therapy from the chemotherapy arm, with an 81% 6-month overall survival for trametinib arm. Additionally, while single-agent trametinib certainly has a lower response rate compared to selective BRAF inhibitors in the BRAF mutant population, the proportion of stable disease, I think, in response to trametinib is certainly relevant. You can see below that at progression, greater than 50% of patients in the chemotherapy group went on to receive other therapies, whereas a minority went on to receive other treatment for the trametinib group, supporting again the significance of the overall survival benefit. And while you have to interpret subgroup analysis with caution, there is nothing in the features here that support that chemotherapy is better than trametinib. I would support the statement that's already been made that there is no wild-type population in melanoma. This is from a paper comparing the number of mutations found in melanoma versus other tumor types, and melanoma tops it all at the end, only competing with lung cancer at this point. And this is just a schematic of current relevant genes, some of them yet to be determined, but involved in melanoma progression as well as melanomagenesis. And so there are targets out there, and it's our job to find out where they are and how best to target them. Improved genotyping, as Dr. Sossman has already presented, alludes to the fact that only 40%, when we only looked at 6 genes, did not have a mutation. When we increased the number of genes that we are looking at in this one that was presented by Dr. Dowd, only 15% of patients did not have an evidence of a mutation, looking at BRAF, NRAS, as well as PI3K. And this has already been presented from the HODIS paper. Not just mutations, but aberrations, amplifications are relevant as well. Biologically driven therapeutic targeting in melanoma is not just for BRAF patients, but also for KIT. And this has been supported across other tumor types. This is from the phase 1 experience at MD Anderson, where they looked at phase 1 patients who had genotyping performed and mutations were determined. Again, melanoma led the pack with the greatest number of mutations determined. And in patients who received a matched therapy for an aberration versus those who received unmatched therapy, while this was not a randomized controlled study, they did appear to have a better survival. I think it's also important to state that we need to optimally utilize our targeted agents. While selective BRAF inhibitors are specific for mutants, MEK inhibitors have shown activity not just in the BRAF V600 population, but also in less common BRAF mutations, NRAS mutations, and other wild-type BRAF populations. Chemoresistance mechanisms are what needs to be determined to better utilize chemotherapy at this point. DNA repair mechanisms, including MGMT with elevated levels, DNA mismatch repair, where MMR deficiency appears to correlate with hypermethylation of the promoter site, as well as PARP involvement in base excision repair pathways, as well as impaired apoptosis, allow cancer cells to survive and not die off. Trials to date have been a bit disappointing with O-methylguanine analogs. At this point, there's been no improvement in efficacy. PARP inhibitors remain to be further evaluated. In an interesting study with decitabine and hypomethylating agent in combination with temozolomide, there was some promising activity. However, in the paired samples in 6 patients, there was no significant change in MGMT or MMR, which raises the question, did the decitabine actually impact the chemoresistance pathway? And in impaired apoptosis, a recent phase 1 study with oblamersen in combination with paclitaxel and temozolomide showed some promising, again, high response rates at 40% and a median overall survival just under a year. However, promising activity was shown early on in combination with dacarbazine that did not pan out in phase 3 studies. Other agents that I think beg to be combined in combination with chemotherapy in clinical trials include bevacizumab, and these are the studies that Dr. Kim already alluded to, ipilimumab as well. And again, the one exception for standard of care would be melphalan in the treatment of patients who are eligible for isolated limb perfusion and infusion, but this is a small group of patients. In summary, no overall survival benefit to date for any chemotherapy, single or in combination, has been established. Current molecularly targeted agents in ipilimumab have established benefit and are well tolerated. There is no wild-type population in melanoma, and discovery and detection of driver mutations and their therapeutic targeting continues to evolve. Chemotherapy use delays and prevents treatment with proven agents and enrollment on clinical trials. There is no standard use for role for chemotherapy in the treatment of metastatic melanoma, only in the context of clinical trials in combination as well as isolated limb infusion and perfusion. Thank you.